Dzień dobry. Wybiła 10, więc chciałbym Państwa zaprosić do zajęcia miejsc. I szanowni Państwo, nie przedłużając, chcielibyśmy otworzyć nasze spotkanie, które ma na celu zaprezentowanie kolejnej odsłony naszego flagowego projektu, który nazywa się Access Gap. Mam nadzieję, że Państwo obserwujecie jego rozwój, obserwujecie, jak się zmienia. 3 lata temu, kiedy pierwszy raz spotkaliśmy się tutaj, bardzo mocno się zastanawialiśmy, jak będzie rezonował, czy będzie rezonował. Oczywiście jest to narzędzie techniczne, pozwalające na to, żeby porównać Polskę z Czechami, Słowacją, Węgrami. Pamiętamy o tym, że zaczynaliśmy z 3. pozycji. Dla mnie jest to też bardzo istotne to, że 3 lata temu po raz pierwszy stałem przed Państwem jako dyrektor Infarmy i po raz pierwszy miałem okazję występować, więc dla mnie za każdym razem to spotkanie przypomina mi o tym pierwszym. Szanowni Państwo, my liczymy na to, że nie tylko i wyłącznie będziemy rozmawiać o kwestiach technicznych, o cyferkach, o kolorach, ale będziemy też otwierać debatę na temat tego, czym dostęp do nowoczesnych terapii jest. Zwracam Państwu uwagę, że kiedy porównujemy Access Gap do Wade'a, musimy pamiętać o tym, że w Wade'cie mamy bardzo, bym powiedział, informacje bardzo klarowne i czytelne dotyczące tego, czy jest podjęta decyzja, czy nie ma, czy są ograniczenia wskazań, czy ich nie ma, jaki jest czas do decyzji. W Access Gapie pokusiliśmy się we współpracy z naszymi partnerami o pogłębienie tych informacji, o próbę ustalenia, co jest przyczyną tego, w jakim miejscu jesteśmy.
Dziękuję, Michał.
Things are as they are. Thank you, Michał.
Obviously, Michał has talked about the solution, the data, and that's very important. As they say, facts are friends. But the real value in all of this is actually the dialogue and discussion amongst all of you. And today is a really a great opportunity to discuss perhaps what are the solutions and what are the things that can be done to build on what is already an improving situation. Michał.
Spotykamy się w tym roku też w bardzo szczególnych
okolicznościach. At a special time.
Jest w trakcie, zbliżamy się w trakcie do końca. Dzięki temu możemy spróbować stworzyć pewne podsumowania, zastanowić się nad tym, gdzie jesteśmy,
because of that, we can already draw certain conclusions. We can ascertain where we are, what we've done when it comes to prevention, digitization, medicine safety, and we've all been part of those discussions, so hopefully today's meeting will also give us food for thought, and we might even come up with where we'll be at the end of June.
Obviously, let's get into the detail, but I really hope that you find this valuable, and again, that we can have dialogue, because the solutions are not simple, it's complex, and it requires collaboration. So enjoy the next 2 hours, and let's proceed.
Liczymy na to, że ta dyskusja będzie miała bardzo duży wkład w zmianę
will make a significant contribution to changing the healthcare system. Today, right before our event, the Ministry of Health announced an update to the Reimbursement Act. We will be working on it, and hopefully after a deeper analysis of that draft, it will turn out that what we've been talking about for the last 2 years will inform the reality of patients, because they are the most important beneficiaries of all of our work, of our discussions, decisions. So thank you so much, and I hope that you will be satisfied with the way we proceed.
Witam Państwa serdecznie po raz kolejny i myślę, że nie ostatni.
Good morning yet again. Hopefully not the last time. I hope to be seeing you for the next couple of years. I just had some neat conversations about GAP and the way we feature data. Because innovations are developing and medicines, therapies are being made more accessible. We're trying to look at a very broad spectrum of disease diseases, also comparing several countries. This type of work usually takes over 6 months. We need to clean out the databases. There's a huge database behind our tool created in cooperation between 4 countries. So this tool has become our reference point for data-driven systems. We try to look at numbers, at facts. They certainly do not take into account a qualitative approach. So what we can see here, whether what we can see in the tool, it doesn't just tell us if things are good or bad, if they're right or wrong. We're seeing a certain section of reality that might spark a discussion. As always, methodology is important. Some changes occurred this year. Rare diseases, oncological diseases. And because we have more and more medicines and more therapies available, more and more technologies, we're trying to look through the lens of molecules and indications. This year we needed to change some things and apply changes to 2 factors, so 5 and 6. And that might bring about certain changes, which I'll show you in a minute. One thing I'd like to get back to, when we're in the green fields, there the situation is relatively good. The greener the ranking, the better. Going down, the darker it gets, blue and then purple. That means the situation requires improvement. Of course, we realize that this is not an assessment of clinical effects, which we are not measuring here. We're just looking at to what extent the technologies are being employed, where the market is at, and we're also looking at diagnostic tests to see whether those are available. So you will have 1 factor per country, breast cancer, lymphomas, and other diseases, but the whole methodology for all the scores have been changed to fit to the newest therapies. Poland has improved its scores because generic medications are becoming increasingly available. So here we can follow 2 trends, the new therapies and how the market is developing thanks to these new therapies. And how new medications can be included in those therapies. Czechia is the current leader all across the board, across all the diseases. The Polish score is 42, was 42, it's now at 61. There's a delay. Most of the time we look at what entered the market by January, but we look at distribution, dissemination, sort of 12 months earlier. So in terms of the changed methodology, only Poland has improved its score. The other countries fell a little. What is alarming is that there is an increasing delay to get reimbursement. We're discussing the reasons at the Ministry of Health. One of the reasons is that this year, either the companies delay their applications to get therapies reimbursed, or there are certain circumstances in the system related to molecules and indications. If we look at scores over time, you see how the methodology changed. This year we changed the therapies that we take into account. There are some interpretive doubts, and we will provide additional information on our website, hopefully also during the breaks. If you look at the situation in 24 versus 25 in Poland, have a look at cancers, oncology, it's similar. Rare diseases, here the situation has improved significantly, and we have some improvement under chronic diseases, which shows that there is continuous improvement in Poland. The question is, can we maintain this trend? And of course, we invite you to the reimbursement radar, where you can see.
Więc największa poprawa, proszę Państwa, mamy w SMA-IML.
which molecules are being introduced. SMA and AML saw the greatest improvements, and diabetes and Parkinson's disease scored lowest. Diabetes slightly improved the score, but still in terms of access, it is a therapeutic area that requires discussion still. If you look at SMA and how it improved, my colleague will also comment on this. Poland is certainly a leader. We have very good access to 3 molecules, and we cover the whole population. Myeloid leukemia, here we also have improved access to new therapies, to new medicines, and more patients are being treated. If we look at which therapies have improved, asthma, diabetes, general diseases, those scores have improved.
Jeżeli popatrzymy już szczegółowo
If we look in detail, you can also see this on the website. Sometimes the change in color is due to a shift of 1%. Some changes are tiny, but they change the score. This is a simplified reality. In AML, Poland has narrowed the gap. Aside from Slovakia, to a certain extent, both Poland and Hungary have improved. But here the indicator has also changed, and we see drops across all the countries due to the new methodology. If we look at the scores that dropped, it's not that the situation hasn't improved. We will be introducing corrections in the next editions. If you look at the changes where the situation deteriorated, that's in breast cancer and lung cancer, because new molecules are available. We have more therapies at our disposal, so we need to interpret this score within a broader context. The reference medicines have also changed, and that has affected the scores. Here we have all the countries fell in breast cancer, which means that new molecules have arrived. And that led to some recalculations. Why will we be making corrections? Well, there are so many medications out there. If we add generics to that, it's impossible to maintain the whole database because it's a huge database, and we need to adapt. And weight keeps changing its methodology as well, once every few years. Similarly for lung cancer, and here we have made very detailed calculations when it comes to access, the spread of medicines on the market and the number of patients. If we look at lymphomas, here the new situation is accounted for. Monitoring the situation, we see that some guidelines have not changed. ESMO 220 MCCA, we needed to use that to look at the newest guidelines regarding therapies. So for lymphomas, the situation hasn't changed dramatically in Poland, whereas in other countries, because some indicators have changed, some data has changed, and new therapies have arrived on the scene, and that situation is improving slightly. Still, we can still see that Poland has a lot of catching up to do. If we look at widespread diseases, diabetes has improved, but it's still not comparable to other improvements. SMA is our leader. And secondly, the arrival of new therapies and their dissemination. Poland has one of the biggest restrictions. In fact, all the indicators show that this impacts our score the most. So a summary of Poland. Just looking at various indicators. SMA is our reference, testing is another issue, but the green squares are good areas, and the dark ones are the ones that need a lot of improvement, including diabetes, plus in lymphoma. We see restrictions for patients in terms of access to certain types of therapy.
chcemy powiedzieć,
And
że
so,
ogólnie oceniamy sytuację jako niezłą.
generally, we
Poprawiają
see
się
the situation
programy.
as
Widać, że
relatively good. It's
ministerstwo
improved
dzięki
for certain
liczbom, które
diseases. The ministry,
możemy się
thanks to the
informować,
numbers
poprawia
it publishes,
sytuację w dostępie do leków.
we see that
Niepokojący
access
jest
to
fakt
therapies has
wydłużenia
improved.
czasu.
It's
No i
alarming
pojawia
that
się
it
pytanie, jak
takes
teraz
longer.
przy obecnej sytuacji, którą mamy w systemie,
The
utrzymamy
question is, given the current situation in the system,
doprowadziliśmy w czasie, myślę,
how can we
wielu lat.
maintain
Praca, można powiedzieć,
availability
od
and access that we've achieved over many years? This work started back in 2020 along with the Reimbursement Act. Will Schnur
I ja chciałabym podsumować, że ewidentnie
change our
analiza,
lives
jak
for the
analizujemy
better.
te dane, też Państwo muszę powiedzieć, że jak analizujemy,
So,
widać,
looking
że ten
at
balans
data,
pomiędzy
we see that
chorobami
there's
powszechnymi, rzadkimi, rzadkie bardzo
a balance
zmieniły,
between common diseases
swoje,
and
myślę,
rare
landscape
diseases.
taki w Polsce,
The
ale
rare
też w
diseases
krajach
landscape
naszych,
has
że widzimy wiele
changed
szerszy
significantly in
dostęp. Terapie,
Poland
które
with
są
broader access
bardzo
to
spersonalizowane,
therapies, personalized, highly personalized therapies, including for cancers and blood cancers. We see that becoming available all across the region. But there's more balance now between common and rare diseases. What we need to think about are the common diseases because of the budget for them. There are problems with reimbursement, and how would we address that given increasing challenges, and hopefully our discussion will touch on those aspects. Thank you very much, and this is where we are at, where Poland is in 2025. Hungary, Slovakia, they're not doing as well. Czechia is the leader, and we're almost catching up to them, so hopefully these scores will only grow. Thank you.
Nie jest. Słychać? Ja mam donośny głos, ale nie wiem. No dobrze, drodzy Państwo, to przejdźmy do dyskusji.
Great. In that case, let's have a discussion.
Tylko poczekamy, żeby było wygodnie.
Which was announced. So let's just wait for the armchairs so we can be comfortable.
Dopingujemy Panu.
Let's maybe give the gentleman a round of applause.
Chwilkę musimy poczekać. Szanowni Państwo, ja może w takim razie
So we need to
ciszę
give it a
zagłuszę.
minute and
Jest mi bardzo miło,
try to
bardzo dziękuję
talk over the silence. So I'm extremely pleased, and thank you to the organizers for inviting me to moderate the discussion for the fourth time. I've been with you from the beginning of Access Gap. My name is Karolina Kosiecka.
Dzisiejszą dyskusję to jest ona szczególna.
I will be the moderator of this discussion. I have that honor. And this is a special discussion because once it's the first time that we have the Polish presidency underway. Previously, we talked a lot about therapies. Today, we will be talking more about health safety, health security, and probably we'll get a bit more politics into the discussion today. I hope it'll be just as interesting as previous discussions, and it's my fourth time moderating this event, moderating this discussion, but it's the first time that I'm here without the Deputy Minister of Health or the Minister of Health. Neither of them are present, but it's Reimbursement Day. The organizers also asked me to announce that. There's quite a lot happening at the ministry, so we'll probably start with that. So hopefully we're almost ready to start. Let me invite our guests to this conversation. It's going to be streamed online, so I'd like to welcome our audience here.
EA Consulting. Coming back to the stage, Michał Beliniak, General Director of the Union of Employers of Innovative Pharmaceutical Companies, Inpharma. Thank you very much for joining me on the stage. Well, like I said, today, this is a day referring to reimbursement, we've already said that the amendment, a broad amendment to the new law, SZNUR, has been proposed, but maybe SZNUR will solve a lot of problems. Director, what is your take on this amendment? Well, first and foremost, I'm glad it is in place. It's already available online, and you can go through it. Well, I had the opportunity of reading it very briefly, and it turns out that some of the proposals supported by most stakeholders were taken into account. So we'll be analyzing it and considering whether some details need improvements and whether there are any surprises. Sometimes this is the case, that there are some surprises in new amendments. So in the context of our debate and the deliberations about accessibility, is that all simplifications are important, and there are quite a few. Minister Kos, at the press conference, he talked about 30 deregulatory elements. This is how we perceive them, as elements that can have a positive impact on different parameters. For example, access time, so time from registration through to access of the patient. And we know there is going to be a change in the proof of accessibility, the element that was slowing down the possibility of submitting applications. It's possible to implement solutions that will improve accessibility to patients a day after the decision. So this is what Access Gap is all about. It's not only about the decision, but what's happening after it's been issued. So we're analyzing why it is the case that patients need to wait for months before the drug that's reimbursed in theory is in the hands of the doctors who can then administer the drugs. So to sum up, it's great that the amendment is in place. It was supported by all stakeholders that were involved in working on the so-called DNUR. And there is a lot of, well, the Ministry of Health was really very open to discussions. So at first glance, the proposals, the amendments reflect our discussions and our proposals and our concerns. So now we have 30 days for consultations, and I don't think this is over. There are still some areas that will require further meetings. So, briefly speaking, today we are working intensively on reaching agreement and making sure that in a year, in the next edition of WAIT or Access Gap, we will see some significant changes, the regulatory changes. Is there anyone who would like to comment? Magda talked about the waiting time, that it's longer. And is there a chance that the new Reimbursement Act will improve this parameter? Well, referring to SZNUR, I haven't seen the new provisions. I only saw the announcements. But I think 4 years ago, this is when we started the dialogue, and we started looking at real feasible solutions. And I think this law reflects the reality. I hope it will be implemented quickly. But the discussions that we held when we assessed different solutions were really important. And now we are making joint clinical assessments. And this is an opportunity for us to make improvements, because we are facing other problems. What we are showing here is a bird's-eye view, and maybe there are some other risks in the organization, in accessibility across Poland. This is key, because these are practical challenges, because the outcomes do not only depend on what we are showing here, on the numbers of patients, but it all depends on what's happening in real terms. So Sznur makes things easier, but there are other solutions in the system: access to diagnostics, access for patients, especially for people who can't be treated where they live. All these things are of essence. In spite of access to therapies, we might have different outcomes. Thank you.
Dzień dobry, Dariusz Kowalski.
Good morning, Dariusz Kowalski. Thank you for the invitation. Ladies and gentlemen, I was waiting for oncology, but since we are talking about diagnostics, I'm a radiotherapist, a clinical oncologist, so I represent oncology and efficacy. Everything that we are talking about, also access to drugs, is supposed to increase efficacy, longer survival, and the rate of many years survival. So, primary and secondary prevention, accessibility of screening, that's one thing, and two, diagnostics. In the case of oncological diseases, diagnostics has to be good. It's not diagnostic where you take 5 samples and you just can't do anything with them, and 6 months have passed. I mean diagnostics done by the right laboratory, by a dedicated doctor, and the first or second time round you can have a diagnosis, and then you carry out molecular immunology tests, because modern treatment involves immunology and molecular medicine. So access to these tests is indispensable, but these have to be good centers, good laboratories that were vetted. And the third element is access to innovative drugs. So, Professor, it sounds as an accusation with regards to diagnostics. Do you think there is a deficit of such labs and centers in Poland? I'm not talking about a deficit. I'm talking about centers that offer broad genomic testing. When you diagnose cancer, and I work in lung and thoracic diseases clinic, and we usually test small fragments, so 1, 2, 3 millimeters large, and based on that you have to stain it, carry out immunohistochemistry, and each time you do the test you have less material. So either you carry out a modern, validated test that is credible, where and you put another 3 millimeters into the machine and you have all genomic profiles, or you can save money, which happened not so long ago. We cut the sample, we make a cheap genetic test, it fails, then we do another test, and then we don't have money for other tests, and we have to start with genomic diagnostics. Thank you for clarification. Well, I wanted us to look for a new name to replace Sznur, because it is not, in Polish, it doesn't give you the best associations. But coming back to access gap, so I would like to give the floor to Professor Pruszczyk. The leap to 92 points in the scoring, it's something to dream of. Almost 100%. Professor, could you comment? Yes, I have an idea. For Sznur, so like in Polish, you could change it into many other names, but the leap that we've seen in rare diseases from 62 to 92, it's a very big leap, and we were really waiting for it, and it's a leap that was made thanks to this hard work and efforts made by the whole environment dealing with rare diseases, not only professionals, but also patients. So this invisible group of patients now was identified by the payer, by the Ministry of Health. And we've been working for a year now to implement the second version of the plan for rare diseases. Because the first one didn't work out, did it? Well, you know what? since we are talking about systemic changes affecting 10,000 different diseases, so acquired and genetic diseases, and the ones whose origin we don't know. And we are talking about 2.5 millions of patients. So the comment, after 6 years of hard work, we failed, and you can't see the outcomes yet, so it's not justified to say that it failed. I retract my comment. So I think 72 points, it means that a lot of things have been successful. I'm looking at the clock, so please interrupt me at the right moment. Magda Władysiuk was showing SME, and let me make a small comment. And Minister Czech, Professor Czech, you are in the first rows. He's the one who contributed a lot to the wonderful situation of our patients in the system. But SMA should not only be treated as a success of our patients, because we are talking about access gap and limitations, but it should be treated as a system. It's not only about reimbursement decisions. I realize that you always have to focus on an indicator that is showing something, and we talked about gene therapy indicator. But as is the case, I think Einstein said it, that things should be made as simple as possible, but not simpler. So the situation is much more complex. First of all, we have a wonderful drug program, which has been functioning since 2019 really well. And access to first registered therapy was given to patients according to registration indicators. So full cross-section of symptoms, from first symptoms through to patients with chronic disease. Gene therapy, by definition, is dedicated only to the youngest pediatric population. And today, Polish patients, Polish SMA patients, are treated with all three available therapies. And the access to therapies is well thought through, and it's really important for newborn patients to be treated as quickly as possible. We have newborn screening, and in many countries, when the reimbursement time was shorter, still in those countries, those newborns lose 90% of motor neurons, and it's not the best for the patient. So when we develop this reimbursement politics, well, I would like our patients to get access to therapy the day after registration. But it's not always the case where the whole population of patients uses it. In rare diseases, things are getting better, also thanks to the dialogue between the ministry and the experts. Professor, so you're not satisfied because SMA?
Yes.
Well, it's not that I'm not I'm satisfied with scoring. I know that it's impossible to accomplish more than 100%. If tomorrow something is registered in Europe, I would like to make sure that the therapy soon becomes available to our patients. But the therapeutic programs keep evolving, and they are a source of good data, real-world data, especially in the area of rare diseases. They offer important information, not just for us, but for the whole community. I wanted to encourage you, ladies and gentlemen, if you want to discuss between yourselves, you can jump in and comment. Well, treating SMA, we did so well. We had a register at the beginning of the decade. We knew our patients, we knew who they were. And the plan for rare diseases, which will enter into force, we have to have a register. Because if you have great register and great reimbursement, but you don't know where your patients are, then this worries me. This is of concern. And we didn't have this problem. So would you like to comment, Madam, on scoring, or do you accept? It's not a concern. It's not an accusation. I'm just showing a broad picture. I don't treat it as an accusation. We are talking about numbers, and we need to understand what these numbers are all about. Madam Professor, I guess, is saying we have a success. We have scoring. And I think, Madam Professor, you could comment on the outcomes, because I don't know the outcomes. I think saving lives is key. And SMA is an example of a very comprehensive, very quick and wise management in the system, where we cooperated with different stakeholders, including a pharmaceutical industry. The whole environment, clinicists, patients, companies, the Ministry of Health, they all implemented it. So it wasn't easy. So SMA could be treated as good practice. And this is an example. And I would like all rare diseases, if there is an evidence that the drug is working, then I think SMA would be a good example that it's possible. And a lot of people who are involved will agree. And so we increased accessibility, and we keep improving this program. So I'm glad, Professor, that you are critical about how we are showing it. We will take into account your comments, how to address it differently. And maybe a new act will be implemented. Now, on another poll, we were talking about diabetes. Professor Kowalska, why? What is the reason? Because today, we are talking about the different context, about security, which is a priority in the EU. Diabetes is a civilization disease. Do you feel like it's not well taken care of? Do we have to enter on a new level? What are the reasons?
Thank you so much for the invitation. I represent the Polish Diabetes Association. Is diabetes well looked after? I think it is. We're trying to do our best. We're trying to do our best for diabetes patients. I'm very happy to see improvements compared to the previous report. I don't want to take too much time. Go ahead. That's why you have the floor. But I'd like to bring your attention to some aspects. In 2023, in November of that year, a declaration was drafted regarding intensifying care and access to diabetes care in Europe. It was signed by the World Health Organization Europe and the International Diabetes Federation. It's a European chapter. This occurred in Belgrade in November 23.
W ślad za tym oczywiście poszło tłumaczenie na wszystkie języki. Ono jest również
The declaration was translated into a variety of languages. It's available in Polish as well.
Czego ona dotyczy, to jest na stronie Polskiego Towarzystwa Diabetologicznego.
Of the Polish Diabetes Association.
Podkreślono, oczywiście mówimy o takim szerokim dostępie równym do opieki diabetologicznej. Na co ona zwraca uwagę? Po pierwsze, na wczesne wykrywanie cukrzycy.
First of all,
I tu mamy lekcję do odrobienia. Na równy dostęp do opieki diabetologicznej. Następnie na wsparcie osób z cukrzycą. My musimy sobie uświadomić, że oczywiście to zależy od typu cukrzycy, ale to w przypadku typu pierwszego to jest choroba na całe życie. I dostęp, wykorzystanie technologii w codziennej opiece, ale też inwestycja w badania nad cukrzycą. Ja odniosę się do wszystkich punktów, natomiast chciałabym się odnieść tak naprawdę do dwóch, ale może w odwrotnej kolejności, bo zawsze zwracam uwagę na wczesne wykrywanie, bo My mówimy, że ryzyko populacyjne to jest 8-9% w Polsce.
The population risk is at 8-9%
Może jeszcze
in
tylko
Poland.
zaznaczę, że teraz w kwietniu
Let me just say that
wyszedł
in April of this year,
wyszło takie podsumowanie, jak Polska wygląda na
summary was
tle Europy.
published,
Też to jest tytuł,
about
to
Poland,
pewnie Pani widziała już,
within a comparative
już ten
perspective
raport, a więc
across
nie
Europe.
tylko na tle tych 4
So
krajów, ale
This
wszystkich krajów
report
Europy.
looks not just
I
at the
odniosę
4
się do
countries,
dwóch
but all the
tematów, do
European
równego
countries.
dostępu do opieki
And on
diabetologicznej
top of this,
i
equal
do
access to
wczesnego
diabetes
wykrywania
care and
cukrzycy.
early
Więc równy
detection, early
dostęp do
diagnosis.
opieki
So equal
diabetologicznej to są jakby
access
dwa
to
poziomy.
treatments
To jest dostęp
involves
do
two levels.
terapii,
First of all,
ale
access
też
to
dostęp
therapies,
do świadczeń.
but also
To, na
access
co Pani zwróciła
to
uwagę, to ma
benefits.
się realnie przekładać na poprawę opieki diabetologicznej. Więc dostęp do terapii. Gdzie
So we
jesteśmy?
have, where are we
Jeśli
at when it
chodzi o
comes to
cukrzycę
access
pierwszego,
to
no
therapies?
to
For
walczymy
type 1
i
diabetes, what
spotykamy.
we're fighting
Mamy
for, what
nadzieję,
we're
że
waiting
się
for,
doczekamy.
and we're hoping
To jest refundacja
to see it come true
insulinowych po 26 roku życia.
is reimbursement of insulin
dla osób z cukrzycą typu pierwszego. Tylko do
insulin
26
pumps
roku życia. Po
after the age of
przekroczeniu
26. They are
26 roku
reimbursed in
życia,
Poland until the age of
sprzęt,
26. After the
przestaje,
the patient
pompa,
turns
osobista
26,
pompa insulinowa
their personal
już nie jest
insulin
refundowana.
pump is no longer
Wniosek jest
reimbursed.
złożony do ministerstwa,
So we have
czekamy
made an
na
application to the ministry and
Druga
we're waiting
rzecz
for
to
the
jest
decision.
dostęp do
Secondly,
nowoczesnych terapii.
access
I,
to
tak jak Pani
novel
pokazała w
treatments.
raporcie, my mamy
And like
jakiś
you
dostęp,
showed in
bo
the
mamy
report, we do have
refundację,
access,
już
some
nieco szerszą
access.
2022
We have more
roku.
reimbursement
Mam na myśli
now
zarówno
than back in
dwie
2022.
nowoczesne grupy terapii,
There
to są
are
flozyny
two
i,
new groups of medicines,
leki insulinowe,
flozines
agoniści receptora
and
GLP-1.
GLP-1
i,
antagonists.
Tak jak to widzimy, no my tej pełnej refundacji nie mamy.
So we don't have full reimbursement. The patient has to meet criteria for those drugs to be included in the treatment. However, looking at the results presented today, they are for 24. In 2025, we've seen new steps in the right direction. However, when it comes to access to novel treatments, not much has changed. There is an appeal from patients because diabetes, just like rare
My
diseases,
działamy wspólnie z pacjentami.
we work hand in hand with patients. There's a host of patients, there are a lot of patients, many patient associations too. So here we would like to expand the list of reimbursement indications. Right now they're too restrictive. We're not able to treat patients in line with guidelines, including the guidelines of the Polish Diabetes Association. Often we're not able to treat them well because of restrictions on reimbursement. There's another thing I'd like to ask you about, and we will be discussing it further. It's one of the pillars of the Polish presidency, prevention. We're talking about reimbursement here, but we have prevention as step one. That's exactly what I meant by early detection. Early detection equals prevention, but preventing the disease. Awareness of diabetes is growing. Type 2 diabetes follows obesity. We have a lot of campaigns to raise awareness. So early diagnosis, early detection. When it comes to diagnosing diabetes, it's quite straightforward compared to rare diseases. There are very simple guidelines, simple recommendations. And when you look at the report and where Poland is when it comes to diabetes detection, we are in the penultimate position. So promoting healthy lifestyles, prevention, awareness raising, it's quite straightforward. Testing your sugar levels, glucose tests or hemoglobin percentages. It's very simple. So a pro-patient factor, even in KP, we have free training, we have free diet plans. It's easy to find. The actions are simple, but they're hard to implement. And like the declaration says, we need support. We need to support the patient patient community, because we don't know of any effective methods to prevent type 1 diabetes. Type 2 diabetes is preventable. And here, we need to focus on prevention and prophylaxis. So before moving on to other areas, diabetes is a disease of civilization. The prevention program, My Health, do you see that as an opportunity? Yes, of course. It's a program of coordinated care. It's definitely worth its money. We say diabetes, but diabetes also translates into cardiovascular disease, other diseases, kidney disease, eye diseases, stroke. We're not elaborating on that, but we remember
Ostatnio też jakieś decyzje zostały podjęte.
the diabetes foot, leading to incapacity. We have a pilot project that has now been expanded to include more treatment centers, and we are hoping that after we finish that program, those treatments will be fully reimbursed. When it comes to diabetes, there is still quite a bit of work to do, but we are working together with patient associations. We're taking note of prevention, prophylaxis, early detection, and equal access to treatments. On the topic of diseases of civilization and how society is changing, here I'd like to turn to Professor Kułakowska, one area where we still have great work to do in access gap is Parkinson's disease. Since the Polish presidency has taken health security as one of its mottos, what are we seeing here? We have an aging society in Europe, and Parkinson's will become more relevant. Thank you for the invitation. I represent the Polish Neurological Society, so Polish neurologists and our patients. Neurology is a very broad branch of medicine, one of the broadest at present, I think. And if I were to give you an unequivocal description of access to neurological drugs, I wouldn't be able to do it in one sentence. Take your time. Because ALS is also a neurological disease. There's no such branch of medicine as rare diseases. Half of rare diseases are nervous system diseases. So Professor Kostera-Pruszczyk is my colleague, a neurologist, and neurologists also treat SMA. Our reference. We also treat multiple sclerosis, which is a green field in the report, so things are fine. And we also treat Parkinson's disease, and that is in navy blue, so things are not good in that respect. It's a neurodegenerative disease, and like other neurodegenerative diseases, its incidence grows as people age, or we have an aging society, so we're seeing more cases of Parkinson's, of Alzheimer's disease, of ALS, and other rare neurodegenerative diseases. So the GAP register looks at novel treatments for Parkinson's disease, levodopa, two other drugs that halt dopamine metabolism. They're not reimbursed in our country. That's not a good thing. But even reimbursed medicines for Parkinson's, because we have a medicine program, B29, infusion therapies in advanced stages of Parkinson's. And that program, unfortunately, includes provisions that do not allow us to give patients access to broader treatments early on enough. We have over 70,000 people suffering from Parkinson's, and we only had 400 patients in the program. So even the reimbursed drugs, in terms of real-life access, it's not satisfactory. Generally, Parkinson's care, in the advanced stages, we need deep brain stimulation, implanting a DBS. This is an interdisciplinary problem at the cusp of neurology and surgery. For a while, we've also been trying to get comprehensive care for patients, stimulator walk-in clinics like we have in cardiology, to stimulate the heart muscle. And it's been going on for years, and the problem is not resolved. So there's definitely quite a lot of work to do here. Looking at the situation in neurology at large, let me refer to the weight report mentioned already today, which shows that we are somewhere in the middle of the list of the ranking for Europe. But the reimbursement, we have 85% of drug therapies, 85 of the reimbursed drug therapies have restrictions on them because they are administered within the framework of drug programs. Neurologists are constantly dealing with drug programs because all of our new technologies are part of drug programs, including SMA treatments. So drug programs are very important to us. In neurology, we have over 50,000 patients who are taking advantage of drug programs. The provisions of these programs are often very restrictive. Administration on these programs is huge. We keep, the number of patients keeps growing because these are chronic diseases. In neurology, we see a great need to reform the programs. But the amendment of the Reimbursement Act, SCHNUR, is supposed to streamline and simplify the system. We're truly hoping for that, but we're counting on it. But if I may just say one other thing, we need a reform, an urgent reform of drug programs, changing provisions, freeing up some of the drugs so they get reimbursed through other programs, and contracts, signing up for enough drugs, so we don't have, or for enough and not too much. The contracts usually talk about fewer patients than we have, and we keep getting new patients. So as doctors, it's terrible whenever we have to choose. We have a patient who meets the criteria to enter the program, and yet we hear from our management that the hospital doesn't have the funding to treat more patients. And it's not up to us doctors to make that decision. Professor Puszczyk wanted to respond. If I may, and then over to somebody else. So in terms of neurology is getting all the new treatments in the form of drug programs, and the access gap appearing here for patients is also due to the fact that this is something you said, but I'd like to highlight this for rare diseases, not just neurological ones. Drug programs are great. They allow us to treat patients, but they involve many challenges, from the size of contracts, the quantities contracted, plus the administrative costs, the human, the remuneration costs for teams that require specialized training and knowledge, and often this is the price is underestimated. And whenever there's a new drug program, we apply to the competition. There was recently a competition for a very, very rare disease, and I was told to submit a list of 5 doctors. If I only enter 2 doctors, we'll get too few points. So I made a list of 5, but I don't think we have much interest in Mazovia. No one's lining up. And it's always the same 2 or 5 doctors because it's all the specialists there are. In fact, we cannot hire new staff when new therapies appear on the scene. And these new therapies will allow patients who previously came to us rarely, they'll come more often because they require in-hospital therapy. So it's a success for our patients, but quick reimbursement won't always solve patient needs if we don't have staff or we run into other problems. So looking at drug access, we also need to consider the whole system, the whole
może pan dyrektor albo czy
environment.
pani doktor, bo chciałabym jeszcze panów profesorów dopuścić do głosu.
Director, doctor, before the professors speak, I don't know which mic. So just to add one thing, and that will possibly resolve the issue of specialist drugs in SNUR in the new reimbursement law. When we analyze the data, we see all the hospitals.
Proszę Państwa, przyrasta strasznie liczba pacjentów, to znaczy, że ten ośrodek musi
So we
prowadzić większą
have
liczbę pacjentów.
hospitals that take in more patients,
Innych ośrodków, mniej lub bardziej,
which removes the burden from other hospitals. These hospitals taking part in drug programs are getting more patients. And it's not about contracts, but efficacy, their efficiency in terms of treating patients other than those in the drug programs. So when we're introducing programs, how do we expand them over time? That's one question, and it's not a simple one. Secondly, how do we move people into specialist drug programs? How do we guide patients through the system, referrals, and so on? Patients that can be redirected because it's hard to coordinate to redirect patients.
Jest budowanie sieci, na przykład neurologicznej.
So we need to be building a neurological network of hospitals and facilities,
To pan profesor,
just like we
pana
have
adwokat, bo
for
chciałabym bardzo panu profesorowi.
Ja krótko jedno zdanie odnośnie programów lekowych.
So regarding drug programs,
profesorów powiedział, że
somebody said that Polish oncology has become the victim of its own success, and that is inter alia because of drug programs, and these are truly astounding for patients. These drugs are very innovative, very expensive, but keep in mind that drug programs have a different way of being accounted for. We have a budget for diagnostics. The drugs are accounted for down to the micromilligram. And what about side effects? These drugs have side effects. They're well tolerated, but there's no way to account for side effects. Sometimes those side effects require hospitalization. The Polish Lung Cancer Association, the Polish Cancer Association, we've written a letter. We submitted it some months ago. We're waiting for a response to include side effects in the reimbursement basket. Getting back to Professor Yiannopoulos, I think you have reason for satisfaction because leukemia the score has improved. So can you say that patients in your area feel more health security now?
Hasłem którego prowadzimy prezydencję w Radzie Unii Europejskiej.
Bardzo dziękuję.
Thank you. In terms of hematology, quite a lot depends on access to new treatments, and that access has improved significantly in recent years. So the rising indicators we saw on the screen reflect our daily situation. So the time to treatment or the time to market negotiations, signing contracts for hospital, that time is shorter now, under 3 years, and in the report we saw 2 areas. Leukemias and lymphomas. Here we've made great strides. We have access to almost all therapies, and those that are not available yet, It's largely because of technical limitations of the given hospital. The procedure has not begun. I'm thinking of the delayed introduction of CAR-T, the Lysocell, for aggressive lymphomas, but that process is underway. Access to therapies, we saw progress for aggressive leukemias, and that relates to technical progress in the area of leukemia, where nothing much was happening since the 70s. So allogenic transfers, chemotherapy were leading therapy. Many patients did not qualify with co-occurring diseases, and the survival rates were dramatic. They were under 30% and under 10% for older patients. It was quite dramatic. It started to improve along with targeted therapies plus intensive chemotherapies for younger groups not qualifying, epigenetic medicines, and so these new therapies are available.
Unfortunately, we do not see everything, because in the case of acute myeloid leukemia, we see some periodic appeals by patients. For example, they are complaining that they don't have a diagnosis. If you're older, you don't have a diagnosis, or even if you have diagnosis, you have to wait for a very long time, and you don't see this in the report. We just see people who are qualified for modern therapies at a later stage. And we agree with the international recommendations, with a small caveat about the 100% and those areas marked green. Unfortunately, this situation is not as good, because the settlement tool does not fulfill our expectations. Those 3 levels of genetic testing, well, the highest one doesn't always make it possible to use next-generation sequencing, which in acute myeloid leukemias is a standard, especially in younger patients. Number 2, no availability of settlement tools for chemotherapy or for outpatient specialist care. It's not in place. And this is the second important area in hematology, using new drugs in outpatient specialist care. And this is dramatic. You can see this in the case of lymphomas, marked violet. So you can see the increasing population of lymphoma patients who have access to new therapies. I don't know where you have those dramatic data from. It's not as bad. At each state of patient qualification, I'm in the coordinating team for CAR-T technology, and those patients who fulfill the criteria, and they are considered eligible. There are no limitations. There are only biological limitations. So if above 1, a patient will not be able to use CAR-T technology. But at least partly, we can interpret it like this. For example, tunomial antibodies used subcutaneously. Well, these patients could use more modern form of treatment. And I give an example from Germany, because I worked there for 3 years, and in Austria, how modern hematology develops in Vienna. So new centers that are being established are satellite outpatient specialist clinics. So the first administration of those antibodies, where there is the biggest risk of cancer lysis. So there's hospitalization or close access to outpatient treatment. So you administer drugs subcutaneously, and we avoid accumulating patients in highly specialist clinics. This is a problem which we see in hematology. And in the new new law, we also have a step in this direction. Yes, availability and accessibility should be more flexible. And we keep talking about it, that outpatient, specialist care. And in Poland, we have more than 100 hematology centers versus 50 highly specialized centers. And it's not taken advantage of in terms of diagnostics. Our diagnostics, in most cases, involve simple procedures that are really simple for us. So biopsy, then cytometric genetic testing, and the first stage is financed indeed, and the procedure was priced well. But so what? If we cannot do a cytometric analysis, so immunology test, identifying the composition of the cells, identifying those sick cells, and diagnostics of lymphomas from peripheral blood. You don't have to hospitalize the patient for that. You just take blood, but we don't know where to send the blood for testing and how to pay for it. It's not like we refer a patient to a ward, because wards have really long queues. The patients with acute lymphomas wait in long queues for a place on a hematology ward. Is it optimal use of the system? Someone's going to pay for this test anyway, but if there is no settlement tool, it will be hidden in the loss of the center. We will still pay for the test, but we won't pay for it the way we should to make sure that the system works properly. Ladies and gentlemen, did you want to comment?
Czy pan dyrektor w końcu się przebije?
Or you, director?
Komentując w zasadzie część wypowiedzi, faktycznie w ustawie refundacyjnej
Well, the reimbursement draft law talks about the fourth category of reimbursement, which is supposed to address your challenges. The fact that these patients have to go to a hospital, even in the case of therapies which do not require hospitalization, because the hospital can distribute the drug. And the conditions of the program are such that the patient has to stay in the hospital. But there's one more important thing. I keep hearing things that show that there are certain elements that work really well. But there's one element that was marked blue, and it's worth looking at it, because we feel that we are going in the right direction, and sometimes we are surprised at the outcomes. So we are making analysis, and I'm not saying our analysis is the only one and the best one, but it's worth looking for obstacles and barriers that are minor from point of view of the whole process. And it doesn't take much to improve them. But the responsibility is fragmented. In the case of reimbursement, we work with the Department of Drug Policy. But the things that you are talking about, there are other people responsible for them. It's not necessarily the Department of Drug Policy, which does see all these things that you are talking about. So availability, months or years, and sometimes it causes a lot of emotions. And for sure, financing. You said it. Yes, we always talk about financing. We wouldn't have a debate without talking about financing. So after COVID, we had a lot of security, but now we have the state budget and we need to co-finance from the state budget. And this has impact on how the patients are qualified. Do they have a chance to use these therapies? There is a declaration that overpayments or excessive services are going to be covered. But well, the money is made available, but the sheer fact that there is a gap, a financial gap,
że tak naprawdę ma to swoje konsekwencje.
It has its consequences for patients. Thank you. Well, Professor,
Tak? Bo ja chciałam oddać panu
I
profesorowi.
wanted to give the floor to Professor Kowalski
Będzie chciała coś dodać. Bo panie profesorze, zaciekawił mnie element
we talked about
rakiem piersi i raka
breast cancer and lung cancer. We see a deterioration here. Is it due to the fact that modern therapies are now old?
Zasady było tak, że
Because it used to be the case that breast cancer was really very well managed, and now we have a deterioration.
rzeczywiście spadło. Jak
So,
to skomentował
could you
wynik
comment
raka piersi
on these outcomes?
53,
So, lung cancer 68 to 63, and breast cancer 53 to 63. I'll comment on the lung cancer.
Szanowni Państwo, ponad 10 lat temu rozpoczęła się...
More than 10 years ago, we started a revolution in treatment of lung cancer, a cancer that was always a deadly disease, and the recovery rate was less than 10%. But today,
W części przypadków,
in a lot of cases, it's considered to be a chronic disease. And, well, some are looking at us and smiling, but still, when you're at school,
chorym wyleczonym.
they teach you that if you survive 5 years, this means you're treated. But today, patients with metastatic disease, lung disease, well, we can treat 50% of those patients, and their survival is more than 5 years. Are they recovered? No, they are not recovered, but they have a chronic disease.
Bardzo dobrym programem
We have a very good drug program for lung cancer.
opłucnej. Brakuje pewnych leków, natomiast nie zgodzę się również, że
Some drugs are not available, but the gaps are not that big.
rejestracje
Some registered drugs are drugs of the same class, anti-PD-1 and anti-PD-1. They are registered under a different name, and they can be used with the same indication. So things are not bad,
dobrze.
but things are not good either,
Postęp, jaki
because the biggest progress in oncology applies to lung cancers. A year ago, FDA published a ranking of top new technologies. Lung cancer was ranked first. 20 new breakthrough molecules were made available. So a lot of drugs are missing, and I don't want to quote their names. They are not just immunotherapy drugs, not just immunocompetent drugs, but also drugs which are molecular drugs. And it pains me that this small population of patients has no access to these drugs. We are talking here about rare diseases, but lung disease, lung cancer, we have 24,000 new cases in Poland. And it could be a rare disease, in fact, because if the rate of a specific pathogenic variant is 1 or 3%, this means several hundred patients a year. And now when we are doing molecular profiling and next generation sequencing, the molecular pie can be cut in such a way that we offer dedicated drugs for a concrete molecular type of the cancer. And that's why we have such a spectacular success. 7 years ago, patients with BRAF gene in melanomas, in the case of non-small cell carcinoma, EMEA registered 2 drugs, tremelimumab.
To są trudne
I forgot the name, sorry, dabrafenib. And for 7 years, we were not able to cope with that. We weren't making it available to Polish patients. Now there is a light in the tunnel. We have a new generation of drugs, and there's probably going to be a drug program. But it's a continuous progress. We need to keep catching up. But generally speaking, thank you to the fund and the ministry, because the Polish drug program is not bad when it comes to pleural mesothelioma and lung cancer.
Powiem tak, pan profesor,
tak już podsumowując,
Yes, to sum up.
Państwo zauważyli taką rzecz, że gap
I'm sure you noticed that the gap has shifted and we are sort of chasing things. Some things have improved. So on the one hand, some values have dropped, but that's because the shares of patients have been growing, because we have a year of delay vis-à-vis the number of patients. So we can see a continuous improvement. We are not removing old drugs, but we are adding new drugs. And in the lung cancer, new molecules were added, and the denominator increases. So the numbers have changed. So gap is not that easy to interpret. It's more important to talk about qualitative indicators. But there's one more thing. So now we are at a stage of which I was dreaming for 25 years. So we're talking about facts and numbers. And we already said it. What we are missing, what we don't have, where are we? We are able to show it, presenting figures, both hospitals as well as the payer NFZ. Well, and data from NFZ have a totally different nature, but anyways, we are able to analyze what's happening in clinical practice. Digitalization makes it possible, and that was my dream. I wanted GAP to include digitalization because I could show you the Czech Republic or Slovakia, how they have been accelerating to analyze data. Yes, I wanted to ask about it. It's really difficult to compare because you can't measure it with simple figures. When I talk to the Czech Republic and other countries, well, their systems are accelerating, and that's because they have more know-how in the system, thanks to digitalization, because what you are talking about can be measured, and it is my dream that we keep talking about this progress, not only in terms of drugs, but in terms of data. 10 years ago, in Inpharma, we developed a report about RSA, and we talked about SMPT. And now, 10 years have passed, and we are talking about the same thing. So this is my dream. I don't want to talk about big changes, such as broad amendment to Reimbursement Act, SNUR, but also about other things. So we should be using digital tools. There's no other way out. Poland is considered as a country that adopts digitalizations really quickly. So we should do it in healthcare as well. So not just e-prescription, e-referral and others, but also we should have access to information. Thank you. Yes, you just supposedly dreams do not come true, but you have to implement them. I have a request to you. Yes or no question. Health safety that we see in today's data. Do we have health safety or not? Yes or no? Without any comment. Yes. In diabetology, it's bigger than before, but there's a lot to be done. In rare diseases, 3% of patients have registered dedicated therapies, so we need to work on visibility of all patients. But yes or no? I refuse taking position on this one. In lungs, yes, by all means, yes. Rather, yes. Yes and no. I knew you'd say that. And Professor? We have a lot has to be done. Thank you very much, ladies and gentlemen, for this discussion. Dyrektor Michał Bojliniak, Mardena Patosik, Alina Kułakowska, Professor Dariusz Kowalski, Professor Anna Kostera-Pruszczyk, Professor Inna Kowalska, and Professor Krzysztof Yavopoulos. And ladies and gentlemen, I encourage you to listen to a presentation by MEP Adam Jarubas, President of the Public Health Committee. Due to his duties, he couldn't be here personally, but we made a recording, and I encourage you to listen to what he has to say.
Miło poznać. Do widzenia.
Poprosimy pana, co prawda do Brukseli kawałek mamy, ale czy też do Strasburga, bo nie wiem, gdzie pan
So just to bring you a bit of Brussels or Strasbourg, I don't know
No,
where.
drodzy Państwo, ten filmik ma dłużej niż 2 minuty, więc tej ciszy to ja już nie będę w stanie zagospodarować. Znaczy mogę, ale nie wiem, czy audytorium będzie zainteresowane.
Just over 2 minutes, and I'm not going to talk over the silence.
Szanowni Państwo, za nami ponad 5 miesięcy polskiej prezydencji w Radzie Unii Europejskiej. co oznacza, że powoli dobiega ona końca. W tym czasie diametralnie zmieniła się sytuacja geopolityczna i w tym kontekście jej hasło Bezpieczeństwo Europo nabrało jeszcze większego i szerszego znaczenia. Po doświadczeniach pandemii COVID-19 nikt już nie ma wątpliwości, że jednym z kluczowych bezpieczeństwa jest
health as the general condition of a population, of society, and as the efficiency of the healthcare system, and uninterrupted access to drugs and therapies. So today we are even better equipped for action and cooperation. The Polish presidency agenda, as expected, specified the priorities for the European Commission's current term. And most importantly, we are already seeing the effects. It is worth mentioning that even before the COVID-19 pandemic, serving public demand, wider involvement of the EU in public health had already been raised. COVID-19 only accelerated these efforts. This crisis, on the one hand, highlighted the EU states' problems in dealing with healthcare challenges and the limitations of the European Union itself. But the crisis also demonstrated how much more effective we can be in the EU when we act together instead of competing and driving up prices for limited resources. As Jean Monnet, one of the founding fathers of the EU, said, the Union develops not despite, but thanks to crises, because those give rise to a natural grassroots willingness to delegate state powers to the EU in search for better responses to shared challenges. So COVID-19 could be called Monet's moment in healthcare. Today, these words are even more meaningful. In response to these challenges, one of the signs of the growing importance of health within the EU is advancing the Subcommittee on Public Health to the rank of an independent standing committee, which I have the honor of chairing. Creating this committee was also a response to citizen expectations of wider involvement in the EU involvement in healthcare after the COVID-19 pandemic, but also earlier expectations. I'm very pleased that this coincides with the Polish presidency, as it allows even more effective action and defining the agenda for the European Commission. The priorities of the Polish presidency address well the EU's current threats and challenges in healthcare. The key competence of the Sant Committee is working on the EC's health legislation initiatives in healthcare. The committee has received the pharmaceutical package to discuss the biggest reform of the drug market in 20 years, aiming at improving the accessibility of drugs, including treatments for rare diseases, antibiotics, across all member states at a cost that is affordable to European patients and EU state budgets. I hope that the work led by Poland will bring us closer to a compromise and the implementation of this very important reform, crucial to drug security. Summing up the Polish presidency, I would like to highlight the significance of concluding work on the European health data space. It's a foundation for a strong European health union, which we are constantly striving for. This regulation establishes a common framework for the use and sharing of digital healthcare data within the EU. It also benefits citizens directly. Citizens who gain easier access to their electronic personal data regarding their health, and they will have control of that data. On the systemic level, it will also make it possible to reuse certain data for public activities, for research. It will also create an integrated health data space that will facilitate the functioning of the single market for digital health services and products. The regulation also establishes a harmonized legal and technical framework for electronic systems of medical records, which will bring about interoperability, innovation, and the efficient operation of the internal market. Health security is one of the key priorities of the Polish presidency, while the availability of critical medicines is at the center of debates across the EU. We were discussing this at a high-level conference in Brussels this February. And this event brought together health ministers, representatives of the European Commission, the European Parliament, but also pharmaceutical industry experts and patient organizations. Everyone agreed that ensuring stable supply and access to medicines is a shared challenge that requires decisive action. So it's one undeniable success is that we were able to get the Commission to present the Critical Medicines Act, the draft act. And it's one of the priorities of the Sant Committee. This was preceded by multiple talks about the aims of the act. And as per the declarations made during the hearings by the commissioners, the initiative was presented on March 11th. This act is, in a way, a finalization of the pharmaceutical package. It's the missing link of the EU's response to medicines shortages after the critical medicines list and the Critical Medicines Alliance. It's also the implementation of the pharmaceutical strategy for Europe and a milestone for the European Health Union. And finally, it's better medicines security for Europeans, because even if a drug has been invented somewhere and there's funding for it, but it's not physically available in Europe because it ends up in other markets, it's the subject of pressure in international politics, or shipments are cut off by a pandemic, shipping route issues, geopolitical tensions, sanctions, tariffs, maritime blockades, or other ongoing conflicts, then it's no use. So Europe today imports 80% of its medicines and pharmaceutical ingredients. In some cases, it doesn't make certain substances at all. It's fully dependent on external supply, for instance, for cancer, cardiovascular, autoimmune treatments, and ingredients, including APIs. That dependency is, of course, different for the more expensive patented drugs and the cheaper generic drugs. However, we all must ask ourselves, what if, like with Russian gas, what will we do if we have to face a sudden lack of supply? It must be stated that there is a certain level of medicine production on which the health and life of Europeans depend, which marks the distinction between business as usual and security. And we have to secure that level within the EU by bringing in production and supply chains to Europe, by diversifying supply, by looking at reliable partners who share our values and our worldview along secure shipping routes. Health security isn't just about access to medicines. The aging of European societies means an increase in cancers, cardiovascular disorders, diabetes, and neurological disorders. We must take special care of children and young people, also their mental health. That's why both the Polish presidency and the Sant Committee it's a priority for them to ensure prevention and effectiveness. The overview of Europe's Beating Cancer Plan brought some encouraging conclusions because over 90% of the actions have been completed or are in progress in all areas within all the 10 flagship initiatives. So based on these accomplishments, we want to launch similar holistic strategies in the area of cardiovascular disorders, broadly understood, including diabetes, kidney, liver, and blood issues. We have already taken action. We're monitoring the work of the Commission, but trusting that, as announced by Ursula von der Leyen in her exposé in the European Parliament, also expressed in the letter about the mission of the Health Commissioner, the Commission will present such a strategy. This was expressed during many public appearances and hearings in the European Parliament. We have similar expectations for this in the SAD committee when it comes to the action plan for mental health, especially for minors in the digital era. This is very urgent. This urgency is confirmed by all studies, and the most tragic studies show that in 2024, suicide became the second leading cause of death in this age group. This issue was also discussed in many speeches by the Commissioner of Health, and it's part of his mission. So we're looking forward, we're looking ahead with optimism for the implementation of that goal. And the presidency, as we know, is a time of meetings, conferences, formal conferences organized by government, but also organizations, associations, foundations. So going beyond the formal aspect, it becomes a celebration of dialogue and openness to each other's arguments, a bridge that connects European societies along shared goals and actions. And that is what we need most for our security today more than ever. I often get asked what makes a presidency successful. It certainly depends on many factors, but also on external circumstances that are not entirely within our control. In my opinion, the biggest success of the Polish presidency was that the fact that its priorities and motto were ahead of the events that we are now witnessing, predicting the importance of security during the presidency, many months ahead of starting. It allowed us to set priorities that are today a direct response to the challenges we are facing, and these challenges are evolving. Thanks to this, we focused Europeans' attention on what is crucial to them, whereas the actions and initiatives that result from the Polish presidency have become part of the EU's priority agenda and will be continued by the next presidencies. Thank you very much. Thank you so much. MP Jaruba said that presidencies involve many meetings, conferences, a celebration of dialogue, and exchanging arguments. So I'd like to invite you now to another argument exchange. Mr. Grzegorz Cesak, head of the Office for Registering Medicines and Biocide agents.
Paweł
Grzesiowski, Chief Sanitary Inspector, is joining us online. So if we can see him. Professor Marcin Czech, the outgoing president of the Polish Pharmaceutical Association. Dr. Gałązka-Sobotka will also be joining us in a moment. the head of the Healthcare Management Institute from the Łazarski University. Also with us is Professor Paweł Koczkodaj, epidemiology and cancer prevention unit at the Marie Curie State Research Institute. Mateusz Mądry, partner, head of life sciences practice, DZP law firm. Natalie Moll, Director General of the European Federation of Pharmaceutical Industry and Associations. And she is joining us online. And Phil Krzyzak, President of the Board of Informa. Hello to everyone. And I encourage you to be active, to exchange arguments. Like recommended by Mr. Jarubas, because we are here under the banner of the presidency today, and one of the pillars of the Polish presidency is health safety, health security. And since that is the case, I would go straight to Brussels. I suggest we go to Brussels, to Natalie Moll. If you could sum up from your standpoint, if you could sum up the Polish presidency, the priorities that were set by the innovative industry that we're meeting with today, have they changed? Do we still have 1 month to go?
First of all, thank you very much for inviting me. I hope that you can hear me. I heard myself for a second, so I think that is the case. I'm very sorry not to be in Warsaw. And congratulations on the Polish presidency for organizing so many events that really put health at the center. I really believe that Poland's EU presidency has played a crucial role in initiating the strategic discussion, also not only around health, but also around life sciences. You've put the sector on the political agenda with the innovative industry, pharma industry playing a key role, but you've also laid the groundwork for a more coherent and innovation-friendly and resilient healthcare and life science policy framework, recognizing the critical role, as was mentioned just now by MEP Jarubas, in Europe's health resilience and economic resilience as well. I think the focus on health, prevention and digitization of this presidency, so including the support for the European health data space, has been directly aligned also with the priorities of the pharmaceutical industry. The European health data space can be a game changer. It offers a chance to transform healthcare through access to real-world data. It supports the development of personalized medicines, predictive analytics, and AI-driven innovation that can improve patient care and ensure Europe's leadership in digital health. And these are all things that have, I'm sure, come up several times this morning. I think Poland's emphasis on digital transformation and prevention has given an opportunity for Europe to step up and try and lead globally in modern and secure and equitable healthcare. And the event today on access is really crucial to look at all the aspects of a modern and secure, strong European health. Thank you.
Thank you. Phil, to już nie pierwszy raz dzisiaj pojawia nam się cyfryzacja.
Phil, it's not the first time talking about digitization in healthcare today. I know you attach a lot of importance to this aspect. Why was digitization considered a healthcare security priority? Because often digitization and AI isn't always, we don't think of it as a security-related concept.
I think, I'm not an expert in data and AI, okay? But I think it's very clear that it's clearly going to be transformative in probably ways that we can't yet foresee. This morning we've already heard about, okay, time for reimbursement is one aspect, but there are many, many other aspects that need to be focused on to improve access to medicine and security. And I think Michał talked about the importance of finance. Finance requires good data to make good decisions. And I really believe that data and AI will enable us to give us a level of capability to solve problems at a higher level than we're currently solving them. So for me, I think it makes complete sense. I can't foresee exactly how it will impact things, but I think it will change things fundamentally and ultimately improve decision making and improve the allocation of resources and improve our productivity. So I think that's why it's so important.
Bardzo dziękuję za ten komentarz.
Thank you so much for that comment. It's true that working with data is always extremely crucial. However, in our discussions, we'll get back to digitization, but there's something that keeps puzzling me, and it often appears in the context. Oh, I see. There's a party outside. Okay, so we'll be joining you in 50 minutes. So something that keeps coming back in statements by Natalie Moll, also in what Natalie said, it's about prevention. And here I'm looking at Paweł Koczkodaj. Is prevention health security?
Well, hello. Thank you for the invitation. I feel like a peculiar person among people who deal with treatment, with drugs, with prevention. I try to prevent treatment, not to lead to treatment through my measures and through what we do at the National Oncology Institute, epidemiology and primary prevention of cancer. So prevention, prophylactics, in my opinion, it's the basic element for security. But you also need data, don't you? I do need that data very much, because I need to see what's happening in real world. And to refer to some practical examples, secondary prevention, well, in fact, in Poland, we don't really know how many people are covered by screening, because the data is fragmented. We only see what's happening in the screening programs financed by the NFZ, National Health Fund, because NFZ reports these data. But some patients are covered by other parts of the system, and we would like data to be integrated. Just to give you an example here. Now, security. Yes. Today, we talked about the European context. We talked about OECD and the European Commission data. Our analysis for malicious tumors say that we have growing morbidity each year in this group of the diseases. And the question is why? Well, we talked about silver tsunami. The European population has been growing older faster than other populations in the world. So we have our own standardization of indicators. So that's the part we have no influence on. Of course, we would like to have influence on aging processes. We'd like to slow them down and avoid them. But that's not the case. So now, what is the most important are modifiable risk factors that we are, to a large extent, responsible for. I'm sure you've heard me speaking before about tobacco. I keep talking about it at each meeting, because what we hear as people dealing with prevention, well, people tell us, oh, again, you're talking about tobacco. We know cigarettes harm. Well, yes, sure. But if you look at our declarations, our claims as Poles, as Polish people, look at the Central Statistical Office and its data from last year. The question, how do you assess your approach to health? How do you assess your health? More than 75% of adult people say, well, I'm taking care of my health wonderfully, thank you. But that's relative, isn't it? Yes, it's relative. So at the same time, we look at our epidemiological data that reflect the reality, and the picture is totally different. Totally different. So are we a sick society? This is what you want to say? Not sick, but a society that doesn't really take care of its health. We have a lot of studies showing that we are not physically active. A lot of studies showing that often we smoke. Traditional cigarettes, of course, there's vaping. Yes, but there is a new law now. Yeah, I'm sure we are going in the right direction. But in many things I do, I'm very impatient. I want to have outcomes right away, and the legislative process takes time. What the Ministry of Health is doing is the right direction, but we would like to have more. Go to a shop and look at the exposure of tobacco products, nicotine products, and how exposed they are. That's part of the law that could be addressed very easily, and it's not. Well, I talked to Director Łączkowski, and when you enter the institute, in front of the institute, there are six sick patients smoking cigarettes in front of the Oncology Institute. So it's about raising awareness. That's also an important thing, isn't it? Yes, just to finish off what I said, and it's trivial, but health education, the subject at schools, it should be obligatory, really. It should be done. We hear negative comments from the episcopate about health lessons. And these are the things that will generate outcomes in decades, but we need to implement them, just like HPV, HPV injections. So if you implemented vaccinations, if you implement it wisely, you can eliminate and eradicate the disease. You mentioned health lessons. Professor Czech was nodding his head. I wanted to ask Madam Sobotka, because we talked about health lessons in the context of prevention and health security. Well, prevention. We always think about the Ministry of Health, but it's actually interdepartmental thing, like lessons about health, it's education, pro-health approach. It's Ministry of Sports, work-life balance, that's Ministry of Labor. Yes, and infrastructure, which will make sure that kids will use bikes to school, that's Ministry of Infrastructure. Healthy food and not mass presentation of highly processed food, that Ministry of Agriculture, Economy and Finances. So now, to add some negative comment, this is what was missing in the presidency. Health security. It's a very broad discussion. A discussion about the paradigm of the state, about the paradigm of Europe, which is focused on creating pro-health environment for modern Europeans. Pro-health life environment means that we need to redefine economic and social policies. It requires dialogue with business, with farmers, with industry representatives about the fact that we need to redesign our business models and redesign our thinking, just to make sure that we agree that we won't be able to be strong geopolitically if Polish young people are not fit to be in the army and use this hyper-modern equipment, because most young people today in Poland, they are becoming adults in much poorer health condition than their parents and grandparents. So let's talk about facts. Poles live much shorter than Europeans. Poles live much shorter in health than Europeans. Poles leave the labor market for health reasons much earlier. And the discussion about retirement age, in my opinion, is actually about what should we do to make sure people can work at all, because work is a sense of life. It gives you energy, and it's a factor that's anti-aging factor, but you have to be fit to work. So we have to sit at one table and answer the following question. How do we change the conditions of life? Because today, from point of view of disease, which is ranked first in terms of morbidity, it's obesity. Today, 9 million people are obese. More than, several dozen percent are overweight, and that can generate huge complications if you're then obese. So we are living in obesogenic living conditions. There are different advertisements. VAT on water bottles are maximum, and it's the same as on all soda pops. So actually, we have to do a lot of work. It requires interdepartmental, intersectoral discussions. So business, NGOs, administration, local governments, central government, all of them have to join forces. Because when we develop our national economic, military security, you need to remember that health is the fundament of all that. So we need to change the paradigm of social and economic policy. We need to have more discussions on a political level, but also we as citizens. We are not asking for this discussion, this holistic helicopter view approach, because we need to talk in broad terms about health. Mainly, we talk about repair medicine, about diseases, and we need to talk about health. Yes. We don't really want to talk about it. Look at the political emotions when we talk about lessons about health. To give you an example of our colleagues who are taking over presidency after us, Danish, they decided that 5% of GDP will be earmarked on prevention, so investment in pro-healthy lifestyle. And our colleagues from Denmark are saying that the tool that changes the perception of citizens and attitude of citizens is digitalization and access. After all, yes, and access to continuous information about changing parameters of a given person. Last month, I participated in some occupational health tests, and I do not have the results online yet. This is lack of integration. So there are different incidents, different processes that comprise prevention, prophylaxis, and then treatment. So often we multiply services rather than capture the gaps in pro-health activity of the citizen. And the alert, listen, you haven't tested for a long time. Such alert should be in place, and this activates you. Such an alert would activate your attitude. So today, we need to focus on a society that has high health competences. They need to have know-how and implement it in practice. And we have more than 19 million people who have the online health account. The question is how many use it actively. Yes, digitalization is related to risks. And I'm looking at Dr. Grzesiowski. Prevention is also about vaccination, and this is where we see a lot of threats online, a lot of disinformation. Maybe that's why Poles do not trust what is occurring, not trust information online. Well, first of all, if information comes from professionals, it prevents disinformation. The disinformation occurs wherever there is a gap, wherever there's empty space, and wherever we are not present. And the history shows us that when anti-vaccination movements were very sporadic, were very rare, we ignored them as professionals. And we thought if we don't discuss with them, if we don't fight them, they will die. But this was not the case. And the process of denialism is infectious. Denialists are people who are able to present their views really well, and they become popular. But I wouldn't demonize the role of anti-vaccination people. It's some 5% of people who have the right to have radically different views, including their worldview. But the rest of people who have doubts about vaccinations, they are people who simply don't know. They have concerns, and we need to respond systemically. So there has to be a place where if you don't understand whether you should vaccinate or not, well, this person can consult their view. We already started systemic activities. We are creating a procedure, a product that the national health funds will be able to finance, so vaccination consultations. Also, access to data and metadata about morbidity is important. About prevalence, the approach of the society on pertussis or tetanus has changed when we started talking about these diseases. The same happened with RSV virus. When we started publishing data in more real time than once a year, so more frequently than once a year, it turns out that people who have risk factors, they start asking about these vaccinations. So if we implement it, if we offer access to data about prevalence and morbidity, everybody can see morbidity in the region. This has impact, indirect impact on health decisions. But prevention is about well-being, but it's not dependent on vaccination. Of course, vaccination is one of the most effective preventive measures, but they do not apply to all diseases, not even all infectious diseases. So the whole rest is about primary prevention, mainly based on lifestyle, specific lifestyle and behaviors preventing infection. For example, sexually transmitted diseases, where there are no vaccinations, but there are simple ways of preventing, simple, easily available. So there is such a chance. Starting with testing and ending with concrete medical products that we can use in prevention. So by developing a spectrum of preventive interventions, we are making sure that it's cheaper to prevent. It's cheaper to prevent a crisis rather than fight it. There are always victims, not mentioning costs, increased costs. Prevention is not very sexy. Prevention requires new methods, and we need to apply them. How do you convince someone to spend 5% of budget on prevention, and you will win more than 12% more tomorrow, because tomorrow you will have more productivity? Sorry, two speakers speaking at the same time. So prevention gives you a bonus in the budget. So if you could convince finance people with concrete examples, it would be easier to invest in prevention. Thank you very much, Doctor. These are intermediate costs. I wish we had a representative of the social insurance institution who could comment on that, because during COVID-19, it was visible. And we see long-term outcomes. Minister Leszczyna, she said that we will see the outcomes in like 10 years or longer. A short question to Natalie Moll, because, again, we are talking about the essence of data, importance of data. This presidential trio, Denmark, Cyprus, are these important priorities for these countries? Will digitalization be one of priorities?
I think it should remain one of the priorities. Of course, these presidencies will have to deal with at least two legislative files, if not three, with the Biotech Act coming next year. So first of all, there needs to be a conclusion of the revision of the pharma legislation, which is really crucial if Europe wants to update a regulatory system that is now 20 years old and wants to regain its competitiveness and its attractiveness for the industry to innovate in Europe, produce in Europe, and make these products accessible in Europe. So this will be an important file that I know is taking everybody a lot of time, but we need to get it right, and it's a very, very big file with two pieces of legislation. And then there will also be the Critical Medicines Act that I think has just reached the member states and the parliament. And that is, of course, also an important piece of legislation because it's looking at different elements to ensure access, which I know is the topic of your conference today, but also make sure that we have the right reflection since COVID-19, which has been evoked numerous times today, to make sure that we have solidarity among member states, that we always find ourselves as united as possible in Europe and provide an effective response to any national requirements that might be fragmented and that could disrupt the functionality of the single market. So I think these two pieces of legislation will probably take up some time. In order to make sure that we get them right, we need to update the regulatory framework, make sure it's competitive, it's attractive. The Commission has some great proposals, I have to say, in that sense, very future-proof, looking at technologies that might come down the line in 10, 20 years. We don't even know what they might be. With sandboxes, with perhaps the first region to do something in terms of fighting antimicrobial resistance as Europe with a transferable exclusivity right. So really some interesting proposals. And of course, a whole debate I know ongoing about how to boost competitiveness and make Europe attractive in terms of incentives. It will be important considering the geopolitical situation. So I think, yes, digitalization should be important. The implementation of the EHDS should continue at national level as with a European prioritization and harmonization, so that we can make sure that that data travels and feeds into research, but also feeds into patient outcomes and improved healthcare outcomes. But I know that there are lots of other things as well on the agenda of those two presidencies.
Thank you very much. Yes, coming back to the agenda. One of the elements is drug security, and Natalie Moll mentioned it actually. President, you met heads of the drug agency, medicine agency, and you remember very well what drug safety was during COVID-19. What are the main lessons learned, or even the directions which the Polish presidency will set for the future? Because it's about imposing certain narrative in terms of drug security. Hello, ladies and gentlemen. Thank you very much for your invitation.
Temat rzeczywiście jest bardzo skomplikowany.
The topic is very complicated. And we've already held 18 meetings under the presidency. We invited more than 1,200 delegates from the European Commission, as well as from the European Medicine Agency, or chemicals in the agency, competent authorities, not only for medicinal products, but you need to realize that security today, or cyber security today, also applies to medical products and other such products. So you have to remember about this group of products, which are key in healthcare today. So the priorities of the presidency involved digital transformation, and we focused here on reflection paper of the European Medicine Agency and artificial intelligence and other key elements. Yes, might I ask about this one element? What happened? How come? Maybe it's really late that EMA started talking about artificial intelligence. Well, it's about flexibility and accelerating procedures, analyzing data quicker. We all want that. We're talking here also about clinical studies, about making Europe more attractive vis-à-vis the United States. So quick data analysis, statistical data, of course. AI will never replace clinical studies with patients, but when it comes to data analysis, and we're talking about preclinical trials, ethical issues, so preclinical trials limited to animal models. In this case, we can use AI through to quicker analysis of statistical data. So this makes things easier for regulators and for people who analyze data.
So I would get back to medicines safety in a moment, but I'd like to ask our lawyer about security from the standpoint of AI in EU legislation. What do you see here? A lot is being said about how the EU is over-regulated, that they invest more in regulation than progress. And what about AI and the relevant legislation? How do I see AI from the legislative perspective? Well, good morning, good afternoon, actually, and thank you for the invitation. I think that creating predictable rules for the development of AI, as Europe has done, that was a very necessary step, because as a society we need to agree on a direction for AI to develop in, and I think that the development of these technologies is incredible. Things change on a daily basis, but do you feel that the legislation that we have in Europe right now, does it bring health security in terms of AI? Because there's about to be a discussion on this. There was ACTA 1, 2, and so on. In my estimation, these are good regulations. Of course, time will show, you might say, because we're still waiting for the law to enter into force. But AI, my feeling is, as lawyers, whenever we advise our clients in terms of developing medicines, technologies, and non-medical technologies, AI, which used to be called machine learning, that was a decade ago. And those solutions were out there a decade ago, and right now they are everywhere. And often, that's why EMA was a surprise to me. But the guidelines for AI and algorithms were developed by EMA many years ago. The software solutions that used to be called machine learning, we were a bit shy. They were not that advanced. Right now they are out there on the market. And the Act on Artificial Intelligence systemically is very similar to medical device regulation, which is not the best example of EU legislation, because its implementation was delayed twice or thrice or 4 times, but it's well written. And those solutions, so when it comes to AI and advising how to safely implement those projects, we started doing this 10 years ago. And the system, the AI system that was introduced, is very similar to the one for medical products. It's the producer who classifies the algorithm, assigns a risk grade, and depending on the risk, they have to do appropriate research and development. So the system as such is well structured. We have systems that we don't want to evolve. We don't want to develop. There's consensus on this, but time will show what practice will show. Law itself is not enough. Reality doesn't change because of the law. There's administration, interpretation. There's the way we approach these things. I think it's a sensible balance. Thank you for that element. So we've covered medicines security, and getting back to the chair. So within the framework of the meetings held during the presidency, we talked about medicines and medical product security. I will talk about cybersecurity in a moment. There were many discussions about the pharma review. There was we had a co-repair yesterday. You know the outcomes. We still need a little bit more to gain consensus. So regarding security, we talked about Article 10 of the new provisions, which secures crisis problems, securing supply in the EU, strategic multi-level short and long-term supply. And we also discussed a broader mandate of the European Medicines Agency when it comes to working groups, contact points. and of course a monitoring platform to monitor shortages. So these are measurable elements that we need to make more effective. We need to improve procedures, and we need to cooperate with the stakeholders, the companies, but also the medical community, and these are all measurable elements that have already been implemented, and the European Medicines Agency is already on it. And of course, MP Jarubas mentioned an important law regarding critical medicines. That is a key issue. I don't want to elaborate on that. But from the standpoint of both parties, both sides, the industry and the organs, it's key. There are 200 medicines on the list already, and that list is critical. And the EU, all the agencies, see the need to expand the list as quickly as possible. With regard to cybersecurity, the cybersecurity of medicinal products, especially those online, that is also a key issue. Not just medicines, but medicinal products. We ran a huge survey among all the system participants, and here we need to improve the safety of medical products, those available online, those administered via AI. We ran a survey, and we were all in agreement that the law needs to change. EMDR, IVDR, it needs to happen. I hope it will be raised during the Polish presidency before it's up. We still have a month and a half, but we can start the process. We can get the ball rolling to be continued by our successor. And the next presidencies, the trio that we have agreement in, that they will continue all of our priorities. So we started the presidency at a very interesting time. A new parliament, with a new commission, a new parliament. So the parliament and commission changed. You mentioned medical safety, medicine safety, and the geopolitical situation changed as well. So Professor, I'm looking to Professor Czech. Natalie Moll mentioned building competitiveness. So how are we to anchor these priorities in what is happening in the US, the tariff policy, quite unpredictable? How do you see the future of these changes, both with regard to pharmaceutical law and critical medicines? Well, these are certainly going to be more interesting than before. But on a serious note, I think that this change which occurred in the context of health and medicines security, healthcare data, is that in Europe we're doing more and more things together jointly. And I think that's the biggest gain. So where we are now, like Mr. Jarubas said, compared to the situation 10, 15 or 20 years ago, when at international meetings anything about health was said, it would always be commented by the following speaker, well, okay, but that is a member state competence. We weren't doing anything together. Of course, the political, economic, geopolitical situation was completely different back then. Back then, Poland was a fresh, new EU member state, and it was still sort of proving its case. It was still earning respect. Right now, when Slovenia has higher GDP per capita than the EU average, that's been the case for a while. Poland is ahead of Greece, Portugal in terms of GDP per capita. It's the world's 20th economy. Right now, the Europe of two speeds has sort of ceased to exist. So I think something that makes it easier to coordinate, to harmonize, but better coordinate.
W określonym kontekście, jeśli chodzi o Unię Europejską, koordynować pewne działania zdrowia. Nauczył nas bardzo dużo COVID-19, gdzie potrafiliśmy działać wspólnie, pewnie nieperfekcyjnie, pewnie z błędami, pewnie w tej chwili jest troszeczkę czas rozliczeń, na pewno wiele rzeczy można było zrobić dużo lepiej.
To, co mówi prezes Cesak,
taking accountability now, many things could have been done better.
Natomiast proszę Państwa, no nie marzyliśmy o tym, że Europa będzie tak zinformatyzowana, że będziemy rozmawiać o tym, jak tworzyć interoperacyjność wszystkich systemów, jak z tego wspólnie korzystać, jak budować rejestry dla chorób rzadkich, dane medyczne, jak robić użytek z tego, co jest w urządzeniach medycznych, o czym mówił Pan Prezes, jak harmonizować, jak koordynować pewne działania dotyczące prewencji, co jest priorytetem polskiej prezydencji. To też nie są czasy, w których my dyskutujemy o tym, jak zabezpieczać się przed chorobami zakaźnymi. My gdzieś tam ostatnich kolejnych miałem wielką przyjemność tydzień temu uczestniczyć w międzynarodowym spotkaniu, gdzie przedstawiciele krajów zachodnich z podziwem patrzyli na polski system szczepień ochronnych, że mamy tyle szczepień objętych finansowaniem ze środków publicznych.
Doktor Grzesiowski by się uśmiechnął, ale
immunization system, vaccination system with great respect. Mr. Grzesiowski, is he still with us? Yes, I think we speak in one voice on that point. We have RSV.
Mamy szczepienie przeciwko półpłaścowi, szczepienia dorosłych.
Vaccinations for adults, and the Western countries were looking at Poland with respect, saying, "Oh, you've already got it done." The Austrians said, "We haven't regulated half of it." Is it a rosy picture? Is it all rosy? Well, not exactly, because we are still missing.
Nie mamy świadomości społecznej, że
social awareness that one needs to take advantage of these programs. We're sort of caught in the trap of ignorance as to what aims prevention should serve, and those classes in school which are not mandatory, well, they come out of a certain political game and it harms society at large. If I can comment, here I'm agreed with the other panelists and with the professor and with Minister Grzesiowski as well.
Ci, którzy najbardziej potrzebują takiej wiedzy,
those who need that knowledge most will lose out because they're not going to send their children to such schools, they're not going to sign them up for those classes. We will send our kids, but our kids know these things. So we're going to increase healthcare inequalities just with that one element, because parents don't want sex ed for their kids. So just exclude sex ed from the health classes so everyone goes. The problem seems to be closer to home than we thought. These challenges occur everywhere, both in geopolitics, in the big picture. We need to be prepared for crisis situations, including a potential armed conflict, hopefully not, but Europe needs to be ready. If we are to be a partner, if we're to be able to talk to the new U.S. administration, we need to be strong. Like Natalie Moll said, it's very important Europe needs to be attractive, appealing, so it doesn't become obsolete. That is a risk. So these regulations have to be delivered right down to the end. They need to enter into force so that Europe can redefine itself as a modern area of joint healthcare efforts. As the head of an organization bringing together companies, including American ones, do you see these geopolitical changes? Are they evident? Are there obstacles appearing during the Polish presidency and for the trio? These are very interesting progressive challenges.
Well, it's very interesting time for sure, because right now the situation in the States is very uncertain of what's going to happen, and my own company, like many companies, are trying to foresee what might come forward. In the worst case scenario, it will have significant impact, but we're already taking actions proactively to secure our business and think about how we react. For sure, it's different if you're a European-based company versus a US-based company. You know, there are differences there. And I think I would just add, though, to the importance of the presidency and the language, actually, because language is so important. And I think, you know, talking about health in the context of security has opened up new thinking and different conversations, and I think that's extremely important, because we know that we need to think about drug security and health security in the short term, but also the long term. So all of the comments about creating, you know, the right environment within Europe, it's within our control to do that and to make Europe more attractive for the industry for the short and the long term. So, you know, despite what's happening internationally, I think there is a new understanding that we do need to coordinate, we do need to come together, both as countries but as organizations as well.
To w takim razie, jeżeli w wypowiedziach obu panów
In that case, since both gentlemen talked about this European power, to Natalie Moll, from the standpoint of Brussels, this European power in the context of these geopolitical challenges, do you feel this power rising because security is today more important than ever before?
So certainly, I totally agree of the power of words right now. This is something that is being leveraged in other parts of the world, and we have to be able to answer in a way that correctly represents the value that Europe gives to health security and to all the industries and actors who are behind health security. So obviously it's the workforce, the structures, and then the treatments and interventions that are necessary, whether it's prevention or treatments or interventions, hospital interventions. And I think it's really important in this moment where their defense is obviously high up on the agenda for everybody at European level and other parts of the world, that we don't forget that we need to be able to be strategically resilient in health as well. And COVID really taught us that when we don't have health, we don't have anything. Others spoke on this panel before me that if you don't have a healthy population, you can't even defend yourself if you wanted to. So I think it's a great opportunity to connect different priorities, not just competitiveness, but really security and focus on what it is that we need in Europe to make sure that we're resilient, to make sure that we're competitive, to make sure that we can impact daily lives in a normal context, and in case that we have to face unexpected contexts.
No właśnie, ciągle się z tym zderzamy. Pan profesor Czech.
Yes, we keep having to face this, Professor Czech. So very, very briefly, we talked about coordinating action on the European level, but we need to keep security at the back of our heads. Security that involves several factors, and all of them are equally important. We have military security, energy security. There's also health security. Without health security, we won't be able to function as societies in normal situations, and especially in crisis situations, whether it's a war or any other disaster. So health security involves medicines security or preventing infectious diseases, for instance. So let me remind you, during World War I, some people claim more soldiers died of Spanish flu than in combat. So we need to think about these things, especially in the context of different groups. We need to prepare plans, reserves, make plans for how to behave, how to use the infrastructure, the health infrastructure, should the need arise, where to evacuate hospitals and so on, how to set up the procedures, train them, practice them. All of it needs to be done. It's huge labor. And some people are more advanced on this work. In Finland, they have medical reserves of medicines for half a year, for 6 months in their hospitals. I'd like to know how much we have. Israel, I know they're not in the EU. They don't have shelters in hospitals, but they know which parking lot to evacuate all the sick persons to over the course of one day. Do we have such plans? Are we planning for this? I'm not talking about the 4% of people we can currently put underground, but it needs to be thought through, short, medium, and long term, because it's going to be our safety. Critical medicines, medicines, safety, all the things we mentioned here are all part of security.
Thank you. I wanted to readdress those two documents, but a question to Dr. Grzesiowski, since we are talking about health security under the Polish presidency. Professor Sobotka said that we have to be physically fit. And are there any measures taken, strategic measures in this regard, preventive measures? I can't talk about all of them publicly, but for sure, yes. We are analyzing post-pandemic period and verifying macro plans applicable to the whole country, as well as smaller plans applicable to individual voivodeships, counties, and institutions, because that's the requirement of law. And I'm not only talking here about epidemiological security here, infectious diseases security, but about holistic solutions, among others, those mentioned by Professor Czech. So functioning of institutions during crisis. So solutions related to evacuation, taking over specific roles, and above all, communication with other services responsible for crisis. Because we often fail here, and all exercises have revealed this in Poland, that communication aspect, who takes the decision, who gives the first signal to act. Here, this is where we need to change a lot. As regards critical resources, well, this process is already being prepared. The resources of critical medications. We are working on the list of products, medicinal products that have to be in stock in case of crisis. So critical substances related to infectious diseases, vaccines. We are creating such a list, and we are thinking about a mechanism of securing continuous availability, to make sure we don't suddenly have to look for these products when they are needed. We need to have the resources in some repositories where they can be quickly retrieved. So we are extending the scope of our activities, but we are still waiting with a review of the COVID lessons. The political aspect is an obstacle here, and this aspect needs addressing. So what politicians do during crisis and what do professionals do during crisis? Well, two different things. Yes, a nice distinction. So as regards critical medicines, question to Professor Cesak. Are there any measures taken on the European level?
No to tak jak mówiłem w mojej poprzedniej wypowiedzi.
Well, I've already said it before.
Analizy są długoterminowe.
We have long-term and short-term analysis.
Usprawnienie procesu.
So, streamlining procedures with regard to contact points and activities of working groups. So communication, you mean? Yes, and situational analysis. So not collecting what we need. Of course, we have a contact point where we collect information about missing medications, but we need to know the reasons, how to prevent that and how to develop a strategy for the future. So that's the key for us to develop that, also using AI. So that's important. And looking for groups that could be added to the list ad hoc. Strategic measures as well as ad hoc measures. Thank you very much. And on a final note, Doctor, I wanted to ask you one final thing. The gentleman smartly sort of avoided discussing geopolitical commotions. And let me ask you, Madam. So, after Draghi's report, we are talking about competitiveness, and if competitiveness implementation is delayed, what sort of impact will it have on us? Well, I hope that we are able to set priorities in this geopolitical situation. It's not always easy, because each state functions within certain limits. So within the legal as well as financial framework. But if you look at fund allocation processes, and we've been discussing drug security for several years now. For more than a year, I've been deputy president of the supervisory board of Polfatar Homin. This is a company which has a big state share, and it produces several products from the list of critical medicines. And we face certain difficulties in that company on a day-to-day basis. And I always ask the question, are we able to define our priorities? Because talking about priorities, such a priority as, say, health security is one of the priorities of the presidency. And on a day-to-day basis, health sector professionals live in the situation of financial crisis. So determination. I, as citizen of Poland, of Europe, I see determination. Determination means not only saying what we need to do, but it also means dividing the role of tasks, because certain measures have to be taken at the European level, but implementation has to be done on the national level. We need to define the roadmap for implementing the solutions, because often I feel that we talk for a long time about different issues. When I was on the way to this conference, I listened to experts in the area of military aviation. And the thesis was that China overtook the United States long time ago in terms of technology. So today we are talking about what we should do, what we should be doing. But in fact, we have to be implementing it. Speaking about the drug security without building strong pharmaceutical industry in Europe is in fact giving way to those who pose risk to continued availability of critical medicines. So we should enter implementation phase faster, because our discussion about AI in Europe and last impact talked about it a lot. And we are sort of chasing the reality, while we should be the receiver, the user of these solutions. But we keep talking about whether we can do it, whether it's worth to do it, and in which area can we expect the benefits. Professor Czech and Mecenas Mądry and Mr. Koczkodaj. And we will wrap up. Very briefly. Małgosia, you talked about China. Look at China, which manufactures so many active substances. They discover new molecules. No country has such a big increase in innovations, also in pharmacy, also in medicines. Remember about that. Now, to comment on Minister Grzesiowski's comment that politicians and experts do not often agree. So at the Committee of Public Health several months ago, a document was developed called Drugs, Medicine Security in Poland Against the Backdrop of EU's Solutions. I encourage you to read this report, those of you who care about medicine security. Yes, this was a short advertisement. Thank you, Professor. And the Council. Thank you. Just a moment. And a short sum up. I think it's important to say it. The presidency has its legal and political framework. So it's not like one country decides about everything what's happening in the EU. But I think this presidency, both in terms of style and implementation, deserves a very good note. We've heard that from officials and participants. And I am proud that this presidency had such a course. And what Madame Moll said at the very beginning, drug security was the most popular in those discussions. So Critical Medicines Act was adopted. Also, EHDS closure and huge effort of officials to close European pharmaceutical package. And it wasn't easy. There are a lot of controversial solutions there, but both the representatives of the Ministry of Health and others did a huge effort to do that. And today we talk about medicine security, but the outcomes of the discussions will be seen in a dozen years or so. Because before the law enters into force, before these medicines are implemented, it will take years. But we need to think about security every day. So it involves both supply chain, but also strong innovative industry, which invests in new solutions and is present here in Europe, because security is about thinking about tomorrow. Yes, thank you for this sum up. We can talk about it at the next conference. And Professor Koszkodaj, last word. Yes, I will add a bit of honey to this discussion. When it comes to the presidency and the accomplishments and what can be done in the future, well, personally, as a person who cooperates with the Danish embassy, with Denmark, with Cyprus, our institute works out concrete solutions under the presidency, concrete measures which will be soon implemented. And we want these measures and these solutions to be transferred to national health policy. So it's not just we discuss for the sake of discussions. There are a lot of discussions, yes, but this presidency will generate concrete solutions and concrete indications in prevention. And I'm glad that it's one of the main topics of the presidency, and I feel that it's starting to become a priority in the public debate. And self-advertisement now, I invite you to a conference under the EU presidency next week, European Summit on Cancer Prevention and Control. It will take place in our Oncology Institute, a lot of distinguished guests, a lot of interesting discussions, so we encourage you to continue this discussion. Yes, and European Cancer Hub was recently established. Well, ladies and gentlemen, Professor Czech and Professor Koszkodaj had a bit of advertisement and an advertisement block, and I encourage the rest of you to join the smiling faces. And thank you very much. Director Natalie Moll, thank you. Phil Krzyzek, thank you very much. Kancel Mateusz Mądry, Paweł Koszkodaj, Dr. Gałązka-Sobotka, thank you. Marcin Czech, Minister Paweł Grzesiowski, and President Grzegorz Cesak. Thank you very much, ladies and gentlemen, and have a nice afternoon.
Thank you. Dziękuję bardzo, panie prezesie. Piękne to.